Hello, everyone. This is Maureen Dobbins, the Director of Health Evidence, and we're very pleased to have you joining us today to talk about the systematic review, do community-wide interventions increase population levels of physical activity? What's the evidence? And this is actually a updated Cochrane systematic review. So we're pleased that you were able to join us today. I will be introducing in a moment Dr. Philip Baker, who we are also thrilled to have joining us from Brisbane, Australia. He's joined us in chilly Canada for a couple of weeks, and so he's here with us to present these new results. And just bear with me here for a moment. There we go. So this is the review that Dr. Baker will be talking about today, and as I said, just recently updated. Just a little bit of housekeeping for those of you that have joined just prior to the webinar starting. We will go through the presentation. So Philip will go through the presentation of the results, and we'll be asking you a few questions along the way that we would like you to respond to in terms of polling questions. You've been asked one of those already. But if you do have questions, we will get to those at the end of the presentation. So just really ask that you either use the Q&A or chat and that you send it to all so that everyone can see those questions. And then Philip and I will make sure after the presentation that we go through all of those questions and address those questions, as well as any other discussion that emerges in that section of the webinar. If you are having issues related to being able to hear the webinar, a couple of suggestions that we recommend you use a wired internet connection as opposed to wireless. We found that you really have a much better experience using a wired connection. And if you are having trouble, you can try calling WebEx, and this is the number here, but we've also included that in the chat. So they are very responsive, and they would be able to help brainstorm the issues that you might be having. So just a little bit about the health evidence team. The development and bringing to you of these webinars really is a team effort. And so here is the health evidence team. Heather Hesson was speaking to you earlier as you were signing on. Susanna Watts and Jennifer Yost and Robin Trainer are other staff, as well as a variety of research assistants, as well as students that contribute to health evidence as a resource, as well as the creation of the materials for today. And why does health evidence exist? And really our main goal is to help inform decisions that are being made in public health to ensure that the best available evidence that is available is used in those public health decisions that you are involved in. Health evidence helps you save time in that we've compiled in one place all systematic reviews published since 1995 that answer questions of effectiveness of public health interventions. So what is the effectiveness of different public health interventions that has been reviewed among multiple studies? We've searched the world for all of those that are published and put them all in one place. So it's much easier to find this literature than if you were to go to some of the large databases that exist. Only information relevant to public health effectiveness is in healthevidence.org. It's relevant and current. At any given time, we are only 1 to 2 months behind the published literature. So at any given time, if you were to come on to Health Evidence and conduct a search, at most you might be missing 1 or 2 reviews that currently exist on any given topic. We try to be extremely transparent in our process of how we decide which reviews are relevant for health evidence, as well as how we critically appraise the quality of those reviews. So we do all of those things. We assess relevance. once something has been deemed relevant and will be included on the site, then we assess the methodological quality of each review, which is assessed by 2 staff internally and independently and meet to discuss their ratings. We provide that rating for you, and then we also tag each review using broad public health categories that then make it easier for you to find that evidence more quickly. And all of the tools that we use to guide choosing which reviews are relevant and the quality of those reviews are all available on the health evidence site. And we've tried to ensure that that the site itself is easy to use, it's intuitive, that anyone can come on the first time and find what they're looking for. And then we also recognize that accessing the effectiveness evidence is just one part of the decision-making process. So we also have available a variety of tools that would help you in terms of figuring out how you can use that evidence in your decision-making. And this is the model that we use to guide our thinking around evidence-informed decision-making. And we understand that public health decisions are extremely complex and are made up of or informed by several different types of information. We're focusing, health evidence is really focusing on making it more, making the research evidence more accessible to you, which is that purple oval labeled research in this model. However, we also know that public health decisions are informed by the community health issues in the local context, community and political preferences in action, the resources that you have, both financial and human resources to implement different types of interventions. So while healthevidence.org is really providing you with easy access to the best available research evidence, we know that your decisions will also be informed by these other areas of information, and that it's your public health expertise that brings all of this information together to make the most informed, appropriate interventions for your local area or setting. And we follow a process that's really defined by 7 steps. There's no one right step to start the process, although we do talk about starting with defining the issue, then searching for the evidence, appraising its quality, synthesizing the findings of all of that evidence, thinking about if and how it needs to be adapted to be applicable to your local setting. And then if you make a decision to change a program, to add a program, to remove a program, then how you go about implementing that decision into practice, as well as finally evaluating the impact of making that change. So how successful are you in changing practice? So this is the 7-step process that we follow along with the National Collaborating Center for Methods and Tools that guides us in our work around supporting public health decision makers in making evidence-informed decisions. So we have asked you to the following poll question, which is, who has heard of PICO before, P-I-C-O? Your options being yes and no. I see that we have had some answers about, and so we have about 34% of you had said that you are familiar with PICO, 15% said you weren't, and then about 50% didn't answer that question. So let's just go look at what we're talking about. So PICO is really a framework that allows us to think about what our practice-based question is and how to structure an issue into a question that helps us really define what it is we need and want to know. And it also helps us start to think about how we're going to search to find the relevant information. So PICO stands for, the P stands for the population. It stands for, the I stands for the intervention. So what is it that we want to learn about? What are we comparing that intervention to? So sometimes there might not be anything else that we're comparing it to, or there might be whatever the standard intervention is that's currently being implemented. And then we want to know, what outcomes are we interested in learning about? Sometimes we might also identify a particular setting. So we might want to know, is this happening in the schools, or is this happening in relevant for today in the community? So we might want to be further identifying the setting. If we were thinking of it, and this fits, PICO fits very well for a quantitative paradigm, so thinking about quantitative research. However, we also know that it's very important to include qualitative research in helping put context around the evaluation of interventions. So if we were thinking about a qualitative PICO question, we actually wouldn't use PICO, we would use PS, where we're really talking about the population, which is the situation as well as the setting. So the second poll question that you've now been answering is, how often do you use systematic reviews to inform a program or service? And your options were never, sometimes, often, always. I don't know what a systematic review is. And we're just seeing the data coming in now from those of you that have answered that. And what we're seeing here is a fair number of you are saying that you sometimes use systematic reviews, as well as some of you are also saying you often use them, and a few are saying always use them. We haven't had anyone say that they don't know what a systematic review is, which is wonderful, and a few people indicating that they never use systematic reviews. So thank you for your comments on that. So it's now my pleasure. I'm going to hand the mic over in a moment to Dr. Philip Baker, who is a professor of epidemiology in the School of Public Health and Social Work at Queensland University of Technology. And prior to that, he was the director of epidemiology in Queensland Health, leading the delivery of epidemiological services. And Philip is very involved in the Cochrane collaboration and has been a lead author and co-author on several systematic reviews and meta-analyses on reviews relevant to public health. And we're delighted to have him here today to discuss the findings of his update on community-wide interventions. So handing over to Philip.
Thank you very much, and thanks for the opportunity to present the findings of our systematic review on community-wide interventions that address the question, what's the evidence for community-wide interventions? As Dr. Dobbins has pointed out, the review was first published in the Cochrane Library, and it contains studies that we identified in the past, as well as new studies as recent as November. So this is undoubtedly the most recent and comprehensive review on this topic. And to help our communication with stakeholders, we've also prepared podcasts in 4 languages, and a journal club resource will be released very shortly by the Cochrane collaboration. Just before I go into the review, I'd like to acknowledge my co-authors that are listed here, including Daniel Francis, also from Queensland, Jesus Soares from the CDC in Atlanta, Alison Weightman from Cardiff University, and Charlie Foster from Oxford. The review has also been supported by the Cochrane Public Health Group editors, which were most appreciative of their support. So our goal as a review team was to produce an objective and robust summary of the evidence, taking a global perspective for practitioners, policymakers, and consumers. We know that there have been reviews undertaken by others in the past, which have focused, for example, just on the American context, but we have taken a global perspective in our review. This is a major update of our review that was first published in the Cochrane Library in 2011. We feel this is a rather important topic to have undertaken a review on, because physical activity, the issue of physical activity is important to everybody, because we know that people who are more physically active have better fitness levels and they have less chronic disease than people who are sedentary and don't have the opportunity to exercise. And we're very well aware of the steady increase in chronic disease that has been occurring globally, and certainly if the amount of physical activity can increase in a population, we would expect the population to have a better health outcomes. Disappointingly, amongst a lot of rhetoric and support into different initiatives, physical activity levels globally and certainly in Canada here remain stubbornly high. So it doesn't appear to be a magic bullet so far to be able to bring down the levels of inactivity. So what we're asking in this review is, do community-wide multi-strategic interventions, also known as community-wide campaigns, these popular approaches that aim to increase the population level of physical activity, do they do as they claim? What is the evidence for this? So building upon the PICO principle as explained by Dr. Dobbins, we've presented here our question in the review. So in our P stands for the general population, and this could be communities that had to have geographic boundaries. So it wasn't just describing a cultural group, it had to be a population. The intervention were programs which intended to reach the community, and they were multi-strategic, so there was more than one component to them. And these components had to have the aim at promoting or facilitating physical activity. For our comparison, we looked at studies against, generally against usual practice. And O is our outcome of physical activity. So this is measuring physical activity at a whole population level, not just for a selective group of individuals, but for people of the population. And these have been we were expecting to see reports of these, such as the percentage of the population that were active for the frequency of physical activity. So we wanted to know whether community-wide interventions or campaigns could measurably increase population levels of physical activity. We felt this would be important for policymakers, and that's the reason why we have tried to focus at the population level. So before we go into our findings, we'd like to ask you what you think at this point. You've signed up to hear about a webinar on population-wide intervention. So do these work? What is your view? So looking at the results here, we thank you for voting. We have most people here agree of the viewpoint that these work, of people who have voted, and a couple of people disagree with the statement, and about half of you haven't voted, so that is helpful. So we'll come back to this and we'll see what you think after the presentation. Okay, so what studies did we include? So we are interested, in this review, we were interested in when you put things together as a package, what happens? So when you put different strategies in combination, working together, with the intent of working together, do they increase the population level of physical activity? So we said that the programs had to be multi-strategic, and they had to contain at least 2 or more of the possible six strategies in this list. So there were other publications earlier that tried to basically categorize the type of strategies that were being used. So we looked at social marketing, other communication strategies, counseling, partnerships, working in specific settings, as well as environmental change strategies. So it wasn't just a Rails to Trails program, which would be an environmental change only. It would have to be some environmental with, say, social marketing or other communication. So we undertook this review systematically, and we aimed to be transparent by first developing a protocol and publishing it in the Cochrane library that people could see what we planned on doing and could come back and check on us to make sure that our approach had not changed based on our findings. So we searched, in total, we searched 24 databases, and we ran our searches originally for the back in 2010, and we've now rerun these searches and repeated the whole process which we did earlier. So we also took a special focus on looking at the Chinese language databases. We were made aware of quite early in our first attempts at the review that we had missed a chunk of studies that were being undertaken in China. So these are now included. They were included in the original review as well as in the update. So we ran these searches early last year, but what we did is we identified protocols and that we knew of to identify studies that were in progress, and we worked with those authors to get early reports from them, and we had the information even before they went to publication on it. So we very much appreciate the cooperation of some of the authors that are in the 2014, such as Professor Don Wilson. So we took the studies and we assessed them for trustworthiness. We wanted to find out how trustworthy they would be, and we ranked them as high risk of bias, medium, or low, as well as unclear on several elements of methodology. And the other thing that we did is we would find that authors published multiple papers, maybe they divided up the results, or they had discussed different aspects of their intervention or their outcomes, and we have assembled these together, painstakingly put many of the studies together to uncover really what we believed was going on in the study. And through this process, at least 2 authors independently screened and extracted the data from the study, and we worked as a coherent team. And we were specifically looking for outcome measures around physical activity, and we divided them up between dichotomies, such as the percentage of people physically active in a population, and those which were continuous, such as the number of minutes that people were physically active in a day. And because many studies did not have the groups at the same level, at the start of the study, we made adjustments, and the formula is in the review in detail. And this did, by adjusting, it did change some of our the view of some of the outcomes of the studies, because they were not, the authors had failed to do this originally, and we scientifically that's unfair to do. It's unfair to make comparisons when things aren't exactly the same. You have to adjust for it. That's what we did. So in total, with our update, we have in total screened 27,000 records, and we have looked at 269 papers assessed as the full text. And previously we had 25 included studies, and we are now up. We've found an additional 8, including 3 from 2014, and this brings us up to 33 included studies. So many of you may have seen the original review, so I'm going to focus in on some of the newer studies, because I believe these newer studies add significantly to the evidence base. So these are the studies. It adds to the evidence base because we now have new countries that are contributing to the evidence base, further lower income countries. We now have Vietnam has entered the picture, as well as England and Japan. Okay, so you can see from this slide here that these studies, there's some international popularity in undertaking community-wide interventions. So in total now we have 15 countries, both high and low income countries, have undertaken not only the program, but actually have undertaken an evaluation of their programs that would make of sufficient design to make it into a Cochrane review. And US, China, and Australia have the greatest number of studies conducted, as well as you can see that 2 of these studies have been conducted in Canada, including one with up in Canada's Arctic. Other studies in Europe, in Finland, have also been taken in extreme northern communities. So the characteristics of the communities that we included, we found in total there were 267 communities that were described. Some of these were small villages, even some as small as 500 people. Some were clusters of villages. We also found these interventions being undertaken in urban areas and even in very large centers of high density, such as in China. So some of the regions that were collected were up to 1.9 million people. The studies describe aims towards disadvantaged as well as advantaged populations. So 14 of these of the studies themselves describe their attempts to intervene in low socioeconomic or disadvantaged areas. The key message here is that the evidence base from a coverage perspective is very broad, and hoping that somewhere amongst these range of studies that you can find something in there that might identify, that you might be able to identify with. So we have large, small, medium, high income, low income. We have been quite impressed now by the breadth of the attempts of undertaking and evaluating community-wide interventions. So what was So I mentioned that these were multi-strategic interventions, so it's not just one approach. So we then went and asked, well, what are the strategies that are most popular or being put together? And certainly, as you can see here, that most studies included some form of building partnerships, often sharing the message through mass media or other communication strategies. We've identified that there's been some serious methodological problems in the design of many of the studies. So 18 of the studies we deemed were at high risk of bias, So these had methodological issues that significantly threatened the trustworthiness of the findings, such as where the authors purposely identified communities for the intervention where they felt that it was most likely to work, and they then identified communities which had no capacity for the intervention as their control. So this is the sort of thing that we would identify as high risk of bias, unfair comparisons, which many would have the likelihood of probably exaggerating an effect if there was one. And 10 had methodological issues that we felt it was a bit unclear around the trustworthiness. But now we have 4 low risk of bias studies. These are high quality studies. So half the new studies have been added, have been deemed as high quality, as being trustworthy for their findings. So what have we found so far over the last few years of us undertaking reviews of the evidence? We found a lot of variation in the interventions, the populations that have been used, as well as the outcomes. So essentially, there are no 2 studies the same. There's no two approaches or that are exactly the same. But despite these many attempts, and even including the many studies that are high risk of bias, likely to emphasize an effect, if there was one, few studies reported a substantial or sustained increase in physical activity at the population level. So when we looked further through this and we had assessed for intensity, such as the quantity of stuff and busyness that was being undertaken, we didn't find any evidence that any one program worked better than others. So we have noticed, as I've mentioned, over the last 3 years, following the evidence, that there are some trends have been occurring in the way that people are conducting the evaluation components of these interventions, and to be more reliable and trustworthy. And also the designs themselves for the evaluation are becoming more practical and more sophisticated to the onlooker, such as the step-wedged randomized cluster design undertaken by Solomon in Devon in England. Also cluster randomization by taking groups of communities or taking communities and randomizing them. More innovative methods to target communities with the message, such as in Japan, by using the pay TV, which gives them the opportunity to tailor commercials and messages directly into neighborhoods. So if you're in one neighborhood, if you're in Burlington and you live in Hamilton, your television commercials that you see in Japan can be totally different. And so they took advantage of the sophistication of their communication approaches to avoid contamination. Also, we've been seeing a lot better measurement of outcomes, even in the self-report, using more validated measures, but now the emergence of accelerometers. These are small, sophisticated devices that allow the measurement of activity continuously through a day. So we are continuing to see problems in some of these new studies. Half of these are not randomized, and earlier we found identified studies where the information about the outcome of physical activity at the conclusion of the study was appeared to be purposely withheld by the investigators or otherwise. And again, we've seen at least one study that we have been unsuccessful in obtaining the follow-up data for physical activity, although other measures within the study that were measured were made available. Okay, let's now, I'll quickly take you through some of the outcomes. I think it's best if you have a chance to browse through the download, the review, and have a look. But these, I'm going to take you through some graphs I think are paint an interesting picture. So let's just look at this graph of physical activity during leisure time. So how many people make enough sufficient physical activity when they have a chance to do it in a leisure time? And on the left side is the interventions that favor the control, so you're better off not having an intervention, a community-wide program, and on the right are those that favor community-wide. And what we see here is that none clearly favored the intervention. It's a bit of a mix. And when those bars cross that dot line of 1, that's the line of no difference. Okay, now this slide here is the percentage of people who are physically active meets the guidelines in a population, the comparison between the groups pre and post. Now, let's look at the top 4 green dots. This data has come from 3 high-quality studies. And if we look at the dotted line of 1, all of these sit on or around the line of no difference. So there's no evidence that these high quality studies show that the program had no effect. Now, if we look down just a little bit on the, we again see most of the studies hovering around the line of no effect, with sometimes a little bit shift to the one or the other, but only one study here at high risk of bias was clearly one of the ones in China indicated an effect of community-wide interventions. Now, this one asks the question about, for people, what percentage of the population are physically inactive or sedentary? And on the left, we're switching sides now. On the left indicates those interventions which were favored community-wide. On the right are those which favor the control, so you're better off not having the program than having it. And so again, we see this as no evidence that the of an effect. So there's So I mentioned that we were also interested in the continuous measures. There were 7 studies measured, had some form of continuous measures, and 3 of these showed some evidence around increasing physical activity. And one was a study by Simon, which is a school-based intervention in France, and we're not surprised that this program found an increase in physical activity because it was primarily a school-based program reaching into the community, involving people in the community, but the only people who the representatives of the community were actually children and not adults. So it flipped things on. In many studies we see children are being excluded and only adults being measured in community-wide programs. This one flipped it upside down and only reported the physical activity levels for children and not for adults. The Crocker was one which showed some evidence of effect. This is another study with methodological issues, and it was only for women. And the Wendell-Voss, there was, when we did pre-post against the level of background of a decrease in physical activity, there was some significance, but it did not actually increase physical activity. It just seemed to have stalled the decreasing level of people being active. I'll just take us through just a few of the new studies, give some outline of the sort of programs that we've now included in the review. So this is a study by Go, first published in 2003, and then they did another republication of the same study last year. And they called this program Check the Community, Interventions for Health. And this is fairly typical of many of the studies undertaken in China that are intensive, and they go door to door, and everybody participates in the community. Participation rates of over 95%. People will have their blood pressure checked. They will have their weight taken, and when they return, they will be lighter than when the Check the Community people first came out to check them. And obviously involvement with the Communist Party community people. This is how it's been described to me, and also if we're reading the interventions and many of them. So the ones undertaken in China, such as Go, are fairly intensive. And this one was undertaken in, it started in 2009 for 2 years. It had social marketing, other communication strategies, and they found a decrease in the number of people who were inactive and an increase in the energy level at the population level. However, we warn that this study is at high risk of bias. They identified the community for the control, which they stated had no capacity to do the intervention. So the communities without the capacity became the control. Okay, this is another new study undertaken in Devon in England of 100, this, I think one of the most innovative designs that has emerged so far, 128 villages in rural regions. This is somewhat more affluent than other places which have undertaken community-wide interventions, a broad age of the participants. So that what they did is they rolled the program out to all these communities, but they did it in a way that they continually measured physical activity levels of all the villages, but as they rolled it out in a random way, in a way that non-deterministic, and therefore the communities, as they rolled out, became the comparison. So this design has been used elsewhere, and I think it's the first time it's been used in this type of evaluation. And I really believe that Emma Solomon should be congratulated on her work on this study, and it was formed the basis of her PhD. So they did 12 weeks of intervention to begin with, followed by 12 months of support. And with all the investment that was put in by the community, the region, there was no evidence of an increase in physical activity at the population level. Again, this is the one which I've mentioned earlier by Don Wilson. It's called Positive Action for Today's Health. And this, in contrast to the one by Emma Solomon, they went right to underserved, low-income, high-crime communities in the U.S. And this is interesting. So they focused in on walking was the key message. They used social marketing as well as did environmental changes. They did partnerships with police and made the trails safe. The measure of physical activity in this study is is reflecting the increasing trends in becoming more scientific and reliable in the way we measure outcomes by using accelerometers. And so they measured, they identified members of the population, representatives of the population who wore accelerometers. And so they were able to gather data over like a 7-day period. pre and post, and they also measured the population impact of their intervention by looking at how many people were participating in the walking groups, looking to see people walking. They did see more people join walking groups, and they viewed, they could see people in the community walking, but on that individual level and at the population level, there was no difference in the moderate or vigorous levels of physical activity undertaken by those representative of the population. So in our update, we've tried to help communicate these findings to our stakeholders and you, our readers, in a way that is hopefully more accessible. We certainly, those of you who have looked at the first review, we'd like to we welcome your feedback. So we've now undertaken a summary of findings table, and we've divided up the evidence around the trustworthiness to those using grade. So the measure of dichotomous measure of percentage physically active, there were 25 communities fell in this group representing 10 studies. The quality of evidence was quite low, and amongst these high risk of bias studies, there is typically no evidence of a benefit. And again, on the same measure, we found in the higher quality studies, 3 high quality studies representing 160 communities, typically no evidence of benefit. And again, looking at the energy expenditure, our continuous measures on our low risk, our low quality levels of evidence, we found, again, typically no evidence of an effect, ranging from some harm to some benefit. In terms of physical activity, daily average minutes of moderate to vigorous activity, again, and typically no evidence of an effect from the baseline of the communities of 36 minutes a day. And that has come from one study, one high quality study, and because there's only one high quality study, we've said that evidence is only moderate strength. Okay, so what's our overall considerations here? What's our overall study? What's our overall story from our finding? What appears now to be a broad global base of evidence. We've added to this evidence 4 trustworthy studies, and disappointingly none showing an effect in favor of community-wide campaigns. Although it makes sense to combine interventions, there is no consistent evidence of benefit occurring amongst these of what has been tried, and I think that's the important part. It's so far what has been done, the approach that has been done, we don't see an evidence from that approach. So we see that some of the interventions appear to reach segments of the population. Some of these programs have engaged people, and some people, and it becomes visible that people are out doing physical activity, but it hasn't translated to a population level or even to the individual level. So perhaps even some people have not stopped their physical activity, but they have swapped it for something else that is then observable by the program. And so we've also found that some studies showed positive effects, while others decreased levels of physical activity or had no effect. And we'd be cautious with some of those conclusions about the positive effect or the decreasing levels of physical activity, because those were high risk of bias studies. They were studies that lacked trustworthiness. So I do think that we can learn from the evidence base that's been presented to us. And I think the first thing is that we cannot assume by doing lots of stuff, putting lots of things together, being ambitious and will yield a benefit, will yield a benefit at a population level. So there's a potential here to waste money, or some might even point out that they might make things worse. The other is that you can't, you might see more people out walking or attending events, but it doesn't translate into the population level, a net increase. So if you're a policymaker and your claim is that your program is to increase your goal, if you are a public health decision maker and your goal is to attack the stubbornly high rates of physical inactivity, these approaches, there will be caution made in trying the approaches here that have failed to achieve a difference in the level of the population of physical activity. That makes sense. Okay, so we believe that you shouldn't label these groups as evidence-based, and we can't do nothing is the challenge that's before us. So it is worth trying, but a new approach may need to be considered in identifying a way forward. There were some things that seemed to reach the population, and certainly some of the environmental strategies seem to be promising, and certainly that the study by Simon was promising around school-based. So we would suggest that in the approach to undertake a community-wide approach, it would be reasonable to consider the individual components and the effects that are shown from systematic reviews such as school-based approaches or systematic reviews that promote walking in groups as other way of moving forward. So in summary, our findings is that there's a general absence of reporting a benefit for physical activity for community-wide interventions. And some of these programs do see people engaging, but it doesn't mean that this engagement is resulting in either the individual becoming more physically active or the population the population level improving. We have our rates that are of physical inactivity that are stubbornly high. We do need to do something to promote physical activity in the population, and but any approaches that are undertaken should be evaluated to follow up to see, does the program actually deliver upon its goals. From our end, we are working to see what works individually by conducting an overview of systematic reviews. So we're now looking at the broader landscape and saying, well, what are the types of interventions that have been shown in systematic reviews to be effective? And that is a new overview. The protocol is published on the Cochrane Library. We hope to have that done within the next 12 months. Okay. I'd like now, after having done this presentation, to find out what you think. Okay. So we do have some results that have come in, and with the statement, and appears to be less people now supporting of the view that community-wide interventions increase physical activity. So we'd like to go on. So we appreciate your poll. We're interested in what decision makers and stakeholders think when they see when they hear about the review and the findings. And so I just have one more question that we'd like to is, do you agree with the findings of this update? And if you could vote A, strongly agree, B, agree, C, that you're neutral, D, that you disagree, or E, that you strongly disagree. And we'll leave this poll in progress as we then take some of your questions. So thank you very much for sending in these questions. Okay, one of the questions that is very good question that has come in, and we have is one which is the community guide produced a recommendation in 2002, which was a review that was undertaken in around 1999, based on the reviews at that time, community-wide campaigns were identified as effective, or the community guide recommended community-wide campaigns. And the question here is, why have we come up with a different answer? Where's my question? Okay, so the first part is that as we go through time, the body of evidence increases. And so we have now, there were actually only a few studies. There have been many studies published since, as you can see, since around 2000 when that review was undertaken. So we all often think about, we need to stay on top of emerging evidence. We can't rely on earlier studies. And as we all often think about what's happened in populations over the last few years, our settings have changed. Things that people do are quite different. Our methodology was, in our review here, was different than the community, than the Con review, because they included studies which had no control, which were before and after only. And those studies are very high risk of bias and generally recognize that you would not include those in most systematic reviews unless they were interrupted time series. And those studies, which is a multiple measurements before, multiple measures after. And so the study, so we have different forms of evidence that were being considered, and also our view is looking at the population level. So we recognize that at that time that review was what was undertaken back in 1999, 2000, but we now have moved on and have a much stronger, robust base of evidence. We've also got more objective outcome measures such as accelerometer, and also as the measures that were undertaken, there's been more, there's been a lot of, in the last 15 years, been much improvements in the measure of physical activity. So you got to think about a review that's undertaken in 1999 is reaching back way further, because it's having to pick up studies that go much further back in time. So most of those studies, many people I've heard people argue that those are irrelevant for today. So, and also if you include non-randomized controlled trials or in comparisons, that don't have reviews that don't have a comparison, those are extremely high risk of bias. It's also important to realize that review only included studies relevant to the U.S. context. So I hope I've answered your question. Okay, we have a question. I noticed that there is a large range of communities and size of communities included in the review. I understand the advantages, but are there disadvantages to comparing such a range of communities? For example, what works for urban may not for rural. So one of the things that we think about when we do systematic reviews is we try to make the question broad, but not too broad. And we also try to make it not too narrow, that we become with many systematic reviews that are all answering the same thing. So if we did one that answered big communities and we did another one on small communities, we'd have many reviews and a lot of redundant work. So what we've tried to do is our review has asked any size of community. But if you look at, for example, the study that was undertaken by Emma Solomon, that all those communities in that individual study were rural communities in England. All the ones that were undertaken in the Mead study were Arctic communities. So many of the reviews, many of the studies themselves generally focused in on the same type of community, so they're fair comparison. So if you read through our tables, you can see how we have tried to describe the communities. You can, if you're interested in finding out what happened in each of those approaches, the data is there for you. But the overall view is that they collectively, there is little evidence of an effect, or the basically absence of an effect from the evidence. So another question here is, how is counseling considered a community-wide intervention unless done to the whole population being studied, or was it? It seems to me it is a targeted intervention. Okay, so this is an important question because it's to realize that a community-wide intervention is one that has multiple strategies that are being put together. So if we think about the study by Brown that was undertaken in Rockhampton in Queensland, they had, I believe, counseling as part of it. So they encouraged people to be involved in the counseling, but also they had the environmental change strategies. They did engagement with different settings. So because it's going out as a package deal, that's why it's considered to be a whole population approach. So when you put different things together, and you're not measured, the other key thing is that the outcome is not being measured by the individual who's getting the counseling. The outcome is being measured by people who are representative of the population. So some of those people who would have been measured would have not had any counseling at all. And some of the people may have not used trails, etc. So it's about, when you put something into the population, you give people a range of opportunities through a campaign. What is the net effect upon the population? The other question is, did the environmental interventions include any substantial interventions such as community design changes or legislative changes? So again, I would recommend, if you're interested in finding out what the studies did, is to go into the review, and there's a table that lists, I'm just trying to find it right now, the interventions by the types. So there were I can't recall right off the top of my head because we've got 33 included studies and the review is 167 pages, but there were programs which they encouraged the building of trails, signages, etc. So there's a characteristics of studies table that begins on page 48 of the review, and I also have, and towards the back of the review, there is also Table 3 on page 117 has the categories of strategies included. And in terms of environmental components, 14 of the studies had some sort of environmental component. So you could work back. If you'd like to dig deeper, I'd suggest you just work backwards. Okay, so one of the questions is how were issues like length of campaign or per capita investment considered? So we developed a measure which has now been used in other reviews to try to assess the intensity of the intervention. The big challenge that we found was we went through a series of questions on intensity. So we assessed the intensity of each intervention. I'm just going to try to bring up the so this is described in the methods section on page 11 of the review under intensity of intervention. So we went through a series of questions about the development of partnerships, how many items went in. We looked at the reach of the strategies, the level of the intervention, such as where it reached on the logic model in the review, the magnitude of the intervention, the extent of continuous provision of the intervention, looked for any description of the costs, and any statements by the authors as per the intensity, and we combine these together. Now, one of the challenges is that many of the reviews were quite silent on the amount of money that it costs, and we had to go through some of the process evaluations to find out exactly how the programs were delivered. Some of the programs studies, they acknowledged that what they intended to deliver was not at all, was very different than what was actually delivered. So the length ranged from short, from just a few weeks, up to about 1.2 years, and then so that's around the length of the program, and then we also looked to see how the total length of the evaluation period. So whether it was short or long, it really didn't impact whether it was a positive effect intervention. Okay, as for comment on the interventions that showed effectiveness of activity programs at the population level. First, I need to point out is that none of the low risk of bias studies showed an impact upon the population level of physical activity. So in terms of the programs that had an impact, so the question is effectiveness. So the first is that the comments I'm going to say is going to be about the studies which lack trustworthiness. And having said that, I'll come back to the comment about the studies undertaken in China. That's where the effects seem to be reported. So these are very intensive programs where a lot of investment, human investment has gone in, where people go door to door, and participation is expected in people are willing to participate and get involved and be physically active. However, having said that, there is one Chinese study that we identified. They had undertaken the program, they'd undertaken physical activity measurements pre and post, and we made original phone calls to them, but they did not report the follow-up, and they were one of the ones which was had reporting bias, and we were not able to, they wouldn't provide in writing their comments that they made about the effect. So we could not, in the end, state that they, after several phone calls to them, they were not keen to talk to us any further. Can you give a short explanation of what is a stepped wedged randomized cluster versus a cluster randomized controlled trial? Okay, I'll begin. The simple part is the cluster randomized controlled trial. So we can, well, actually, typically in a randomized controlled trial, like say in a drug trial, you randomize people to, say, drugs, but or medications or some program. So a cluster randomization is where we say, well, we're not targeting individuals, we're targeting, say, groups of individuals, so say community health centers, or it could be communities. So a cluster randomized controlled trial is where we say, where we've identified, say, 10 communities that we would like to, would be eligible for the intervention, and we undertake randomization, so like the flip of a coin at a rugby game, toss of a coin at a cricket match, or at a baseball game to decide who will have the intervention. So that's true randomization. It's not, oh, I have an idea that this group might be the control and this group might be the intervention. So that's undertaken through true randomization. So the communities are the cluster. When we step now with the Emma Solomon's step wedge design is where they had this collective group of communities in Devon, villages, and they said, well, we're going to roll the program out. And so what they did is they randomly selected the villages, which were clusters of who could have the program first. So they became the control. So the first 10 that began the program, the remaining 150, I believe, whatever it was, were the controls, and then it continued onwards. So they wedge it out as they deliver it. So that's the step wedge design, and they work comparing each other. So it's a very pragmatic way of saying, well, everyone's going to get the program, but we'll use all the measures, which isn't surprising because often in a clinical trial, even in a clinical trial, people get offered the program later. They may be the control and they didn't have a chance to try the new drug. So I hope that has helped explain the difference. And I really encourage you to read that the paper by Solomon. If you're really interested in using that design, please read her thesis. We've linked to it. Okay, did you include interventions addressing both nutrition and physical activity, such as EPOD? So what we asked here in our review, does a community-wide intervention increase physical activity? So is there an intent to undertake, is there a promotion of physical activity as the main message? Or one of the main messages of the program. So therefore we did allow for interventions which included both nutrition and physical activity. So many of these interventions had a nutritional component as well to them. and others did not. Others, such as Kamada, was focused very much just on physical activity. One of the questions is how strong were the built environment changes supporting walking, biking, etc. in the environmental component of the studies? How do you feel your findings compare with the broader literature on built environments and physical activity? This is a good question because it's leading into what we are doing now with the overview of physical activity. So what are the options that are out there? And so we are currently searching for all the systematic reviews that are of high quality, and we'll be summarizing those and comparing them again, listing them in our review. And I guess in the overview, one of the key things to take an overview is to be very careful of, and can't say that one strategy is more effective than the other, because unless they actually in the studies themselves had that comparison, so we have to be careful with the overview. So I'm going to reserve some of my comments until after we complete the overview and we have a better sense of where environmental strategies. Yes, Dr. Delman can make a comment as well.
Thanks, Philip. I just actually wanted to add one additional comment around how these results compare to the built environment and physical activity literature. I had the opportunity to look at some of this literature on the built environment a few years ago in a review of reviews that Health Evidence undertook, and what struck me as one of our findings around built environment, and in a few particular studies, it was assessing the use of bike trails, and what the finding was that it didn't necessarily result in more people being physically active. It was people who were already active tended to use those bike trails, for example, more. Or they may have changed. Instead of walking, maybe they were now using a bike trail. So now this evidence is a few years old, so it could be that things have changed, and as Philip has pointed out, in an additional review that's being done, we'll be able to get a better sense of what the new emerging literature on built environment and physical activity. But some of those earlier findings from about 3 or 4 years ago, you know, it seemed to appear that it wasn't having as big an effect at that point as what we were hoping. So I'm just going to pass the mic back to Philip for a few remaining questions.
And again, the study by Wilson had a they focused in on the using trails, and they saw people active, but it didn't result in the population level. Okay, another question. Do the findings reflect more the characteristics of the communities included? So we've lost our... So far, the interventions tried so far, the strategies used so far, the methods of the individual studies used to assess the intervention so far, or the methods of the review.
So this is a great question to ask. So I think if I my understanding of what you're asking here is does this have something to actually do, does this have more to do with the approaches that have been evaluated, so something to do with the communities that have been looked at, or the interventions tried so far, or the methods of those individual studies, or is it something to do with the actual method of this particular review? And so I'm not sure if what you're getting at there is if you used a different approach to compiling all of this evidence, would we get a different answer? I suppose one might say that. I mean, what we can say here is that this is the most rigorous way of synthesizing the evidence that exists to answer this particular question, that has included a broad array of the kinds of communities that have tried these interventions, the kinds of interventions that have been implemented, and the ways in which those studies have been conducted. And that when we take what is the highest quality evidence, even though we're taking the highest quality randomized control trials, even within those, some of them are not done very well. But when we take that evidence across multiple communities, types of communities, and multiple types of interventions, we are not seeing the positive impact on physical activity that we would have hoped for. The methods that have been used to conduct this type of review really are the internationally accepted best methods for really trying to get to the best or most truthful answer of what would happen if you were to use these strategies at a population level. So, you know, I guess one of the things that I talk many times with public health decision makers about is what the impact is of the rigor of science on our findings. And, you know, there is evidence to suggest that the less rigorous our studies, the more likely it is we see a positive effect. So, you know, if we had included many, many, many more studies that are of lower quality at higher risk of bias, it could be that there might end up being an answer that came out of a review like that actually does show that community-wide interventions are effective. But then it's keeping in mind that the less rigor there is in the science, the more likely we are to actually see a positive effect that may not in fact be true. So, you know, what this particular review allows us to do is, you know, across many different settings, communities, and the types of interventions, so far we're not seeing those effects that we would like to see, what we were hoping to see. What it does suggest, and what Philip has been saying in his presentation, is we can't stop here. We need to continue to be innovative and think outside the box in terms of we need to try other interventions. The interventions that have been tried so far don't appear to work, so we need to keep trying other interventions that to see if those additional types of interventions might lead to the strategies that those types of outcomes that we're hoping to achieve. So hopefully that answers or addresses that question. I'm sure more than one person likely was thinking the same thing. I just want to pick up on a comment that Joe Byers made, which says, Maureen reminds us of our old community-based heart health systematic review, and certainly does. Joanne and I were involved in conducting a systematic review many years ago now, back in the early 90s, where we looked at community-based heart health interventions that had been implemented in several countries and communities, and really outside of the North Karelia project, that similar type of intervention, community-based intervention, which was then implemented in many other places around the world, those same types of rigorous results were actually never replicated in any other situation outside of North Karelia. So thanks for that comment, Joe. And I just want to bring us back to one final question. I think it's a final question that says, do you think we could cherry pick and find the studies that did show effectiveness and use those approaches if the reliability or trustworthiness was high? I'm going to take a stab at this, and then I'll pass the mic over to Philip to get his take on that. And You know, that's the million-dollar question, really. I think you would need to be very careful about doing that. Generally, the purpose of doing a systematic review is to say when we look at all of the evidence that meets a certain quality level to answer this question, what is the finding? What can we make of that? What is the bottom line? What is the story overall when we look at the evidence in its entirety? And generally the findings from this review is what we know so far of the types of interventions that have been tried. Generally, it is not leading to the types of improvements in physical activity or reductions in physical inactivity that we would like or hope to see. Cherry picking, the challenge with cherry picking here is, one, it might not be relevant to your particular community. And really, what we don't want to do is to go find the evidence that for which we like the answer to and then say, and now we're going to implement that because this particular study said this worked. There could be similar interventions that others have done that show that same intervention doesn't work. So despite our meaning all of the researchers that have done the studies that contribute to this review, you know, sometimes we, despite our best efforts to design the best studies, we end up with results that may happen due to chance, even though it may be a statistically significant finding. And if, you know, who's to say that this one study you might cherry pick here and find it had a positive result, you know, it isn't correct. And the one that said it didn't work is really that right answer. So that's what the challenge is around cherry picking, and that's why you don't necessarily want to be overly influenced by that latest and greatest study that's just emerged. You want to always look at what the body of evidence says when you look at it all together. What is that overall finding? So I'm just going to pass the mic back to Philip. I think he has a couple of additional comments.
Thanks, Maureen. So the issue again with the cherry picking is that is one of the things that we look for when we look for in our primary studies is have the authors themselves cherry pick the evidence, and we call that selective reporting bias, and that people tend to report things that are positive. I guess where we could pick through evidence and pick cherries, I think there is an opportunity for cherry picking, and that's when you're at the cherry tree and the tree is loaded with cherries and you want to fill your vest with cherries. And I think when we have studies which conclude the positive effect, then it can be useful to come back and pick through the studies and find out and ask the questions, which of these studies, we know collectively that there's an effect, but where, which of these studies represent my population, which represent my setting. But I think you need to be at the cherry tree and during the fruit season to be able to go through those. But I'd be cautious again, as Maureen says, as pointed out, to pick through the evidence, pick through the things that don't work and find the ones that do, because that takes us away. Okay, I think we have gone through everybody's questions, and I really thank you for your participation and certainly eagerness and asking. Some of these questions are very challenging, and but I very much appreciate your participation in both the polls and as well as the questions that we've been presenting this afternoon. Thank you very much for your time, and I'll give you back to Maureen.
Well, thanks. I'd like to thank you, Philip, for your time today in presenting what is a fairly very involved review, complex interventions, and some very interesting results. And I'd like to thank all of you for joining us today. We will be we have recorded today's session, and over the next few days, the webinar will be posted in its entirety up on Health Evidence, and you'll be able to access that if there are others in your health department that were unable to join, or if you wanted to check back in to relook at some of the results. So I'm really happy that you were able to join us today. We will be holding monthly webinars in 2015, so please be on the lookout for our invitations to attend future webinars, and looking forward to connecting with you again in the future. So thanks very much. Good afternoon.